All right, good morning. This is Dr. Rutledge. I'm trying again. The first couple of Zoom meetings haven't worked out well, but we'll keep working. All right, so we're looking at my abstract. I thought I'd read it to you as a test. The association of daily food choices with preoperative weight and postoperative weight loss satisfaction following the mini-gastric bypass done by the original technique. Okay? So, the history of bariatric surgery includes a variety of missteps and errors. Think, for example, of the lap band. At present, bariatric surgeons, nutritionists, and surgical programs routinely recommend a pre as well as postoperative diet of a very low calorie, high protein, often called a VLCD back when it was kind of invented in the 60s, including often powdered protein, high fat, most commonly, as far as I can tell, high saturated fat, as well as low carbs. And carbs I put in quotes because that's not really a word. Well, maybe it will be soon. This is similar to the VLCD, very low calorie diets, that were kind of invented and popularized in the 60s, but have since been largely abandoned. You don't hear much about them except everywhere in the bariatric surgery, pre and post-op care community. The present study analyzed the association of pre and post-op daily food choices of sugar, sweetened beverages, as well as artificially sweetened beverages, fatty foods, particularly fried foods, and meat, as well as the food choices on average per day of fresh fruits and vegetables in patients who had undergone the mini-gastric bypass using the original technique. And what we're hoping to figure out is, should we be maybe changing our advice and direction to our patients? Because what we're doing doesn't seem to be very similar to what everybody else is doing. Maybe we need to do a retrospective and go back to the 60s. Anyways, we had about 342 patients so far who filled out the form. Most were women. The mean age was 46 and the mean follow-up was about 7.5 years. And as might be expected, pre-op, we found those people who ate more bad DFCs, that's bad daily food choices. And basically we calculated this by adding the number of drinks of sugar sweetened beverages per day. How many Cokes did you drink per day? The number of fatty foods you had per day. And so that would be like fried French fries or other really terrible high fat foods, cheese, things like that, or servings of meat per day. If you add those all up, how does that predict? How is that associated with the patient's weight when they came to see us? Now, you might not be surprised that it was extremely predictive. In other words, if you drank more Cokes, ate more cheese and fatty foods and fried potatoes, and more meat, you were heavier, okay? Now, that might not seem to be the best scientific paper ever, but I'm proud of it because I'm proud of all the things I do. Well, most of them. But the idea there is, what it shows is face validity, okay? So this paper has got a lot of problems because it just asks people to report, and they're biased. The person who's going to fill out the form is probably somebody who's has had a better result than somebody who's really grumpy about their result. And so maybe the data of the rest of the study is going to be biased or not a really good predictor. But here what we found is that when they told us they ate more bad foods, they were heavier. And those people who had less bad foods, they were lighter. So it was a direct, strong relationship, linear. So every step up in bad food intake made the patients on average heavier. Okay, so that means that our study has what's called face validity. It looks pretty good. It looks like we're measuring and getting answers to something, because most people would agree there's plenty of research that if you eat more high fat foods and high meat and drink Cokes, you're more likely to be overweight. I mean, there's a lot of research on that. So I think the beginning, which doesn't sound that auspicious for the rest of the study, tells us, looks like we are doing what looks like a valid scientific study. Okay? So if you're a scientist, you might know about something called the R squared. The R squared is how precisely two things are related to one another, and one is perfect. It's kind of like correlation. And the R squared is rarely as high, but ours was 0.96, almost 1. So it said basically more bad food the heavier you were when you arrived for your MGB. But again, that doesn't change the world, but it does do something important. It suggests the quality of the study is a good one. It's related to reality. It makes sense. Okay, all right, well, that's good. But then we ask patients, how you doing? And we ask it in a lot of ways, but this particular study, we looked at one of the measures, which was how much did you like your surgery? And not exactly that way, but we said judge it. Judge your surgery, and here are the choices. You could be poor. You say, my MGB was poor. I lost too little weight. And basically 2% of patients out of the group thought their surgery was poor. They lost too little. We could say fair, I lost some weight. That was 7%. And then we asked good, I could lose some more. That was almost 50%, 48%. So pretty good, good. And then the other almost 40%, 39%, said the operation was perfect. So good, 48%, almost 50, and perfect, almost 40. So almost 90% of MGB patients class their operation as being good or perfect. So not bad. Then there was another 2% left over. They said poor, and they lost too much. They had too much weight loss. Okay. Now, having gotten that, first of all, that's good news. You know, these are a lot of former MGB patients. And that they judge their operation good or perfect is pretty good. It's almost perfect. Anyway, so then we said, what about these food? What about these food choices? Let's see. Well, again, I wasn't surprised now. I said a greater decline in bad food, a greater decline in the number of bad food choices per day. Okay, that is, you subtract the number they were eating before operation from the number they said they were eating after operation. That decline was associated with improved patient judgment of their operation. That is, the more they cut back on the junk food, that is meat, fat, and sugar-sweetened beverages, the more likely they were to say their operation was either good or perfect. And again, every step up was linear related. In other words, very, very tightly related. So every increase in the drop, in other words, the more that bad food choices decline, or to not use a double negative, the more the bad food choices declined, the more likely that patients were to say their operation was perfect. Huh? Okay. Now, again, if you just say it out loud, it seems obvious. Eat less junky, bad, fatty foods, you'll have a better outcome. But remember, all of these bariatric surgeons and nutritionists all around the world are saying, no, 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 eat a high-fat, high-protein, low-carb diet. And that's not what this data shows. Also, we tested fresh fruits and vegetables. Again, what we found is every time the patient had more intake, a higher intake from prior to the operation. So if they increase their fresh fruit and vegetables, the more they increase that, the more likely they were to have a good or perfect outcome. And the less that they increased it, the more likely they were to have a poor or a fair outcome. Okay? All right, then we said, what about complication rates? Now, our complication rates were reported by patients, and it was classified first. We said, if you have a complication, they asked to classify it. None, 64% of MGB patients said no complication. Another 25%, so that's almost 90% now, had a minor complication. 7% said they had a moderate complication, and 5% had gallbladder surgery, renal stones, or something else that put them in the hospital. So 95% had no complication, minor or moderate problems. Okay, and again, those people who had less bad food, who had a bigger change of eating bad food, were more likely to have no complications. And the less they changed their preoperative diet of bad foods, the more likely they were to have a complication. And again, it was very linear, it was tightly related. So every time they kept one of those bad food choices, their risk of complications went up. Okay? Finally, one other thing we found this in a bunch of places, although the rest of the world doesn't get it or understand it or agree with it yet, and that is the longer your biliopancreatic limb, the longer the bypass, the more changes there were in the diet. So at least in part, we can see the MGB is part of the dietary change. So as the longer the limb is, the longer the bypass, the greater the change in bad food choices going down, and the greater the increase in fresh fruits and vegetables go up. Okay? So that's what we found, and I think that all makes sense. So we concluded the following. We say, as reported in other studies, the MGB-OT patient reported outcomes were good. They had pretty good satisfaction and pretty low complications and pretty good weight loss. So the study is far from definitive, but in short, daily food choices, both before and after the MGB-OT, appear to be associated with both pre and postoperative outcomes. So weights, complications, patient satisfaction. Specifically, the tailored biliopancreatic limb length, the bypass, was directly related to patient-reported satisfaction, weight loss class, and daily food choices. The study seems to clearly demonstrate that increased bad daily food choices, fat, meat, and sugar-like sweetened beverages, are associated in a direct, linear fashion with both pre-op weight and postoperative outcomes. That is, patient satisfaction, perfect versus good or fair, and also complications. Also, more fresh fruits and vegetables when are directly related to improved outcomes. Okay, so now we kind of talk a little bit, which is bariatric surgery failure rates in 2020 remain high. And the primary reason for failure is weight regain. The number one failure of weight loss surgery, think of the lap band and now the sleeve, is people regain their weight. This is not the first study to show that post-op bariatric patients have a poor diet that's high in meat, fat, and sugar. Hey, this is already known, and the advice, this oftentimes people's bad diet seems to be on advice of the surgeon and the nutritionist. The data supporting the deadly contribution of meat, fat, and sugar food choices to obesity and diabetes epidemic is really overwhelming. We didn't put all the references here, although they're in the paper. But I mean, hello, it's time to read some of the research. And we'll put a lot of references here in the paper. But it should not be surprising then that a dietary study shows that dietary food choices on a daily basis of meat, fat, and sugar-sweetened beverages are directly related to bad outcomes. And with sleeve failure rates now reported between 5 and 30%, the standard preoperative and postoperative management guidelines might be ready for reevaluations if the present findings are confirmed. So anyways, this is our first trial with Zoom. Let's see how we're doing.